The main topic I will talk today is management of severe COVID-19 cases of Ramathibodi Hospital. These are all issues I will be talking about. I will be talking about the intubation, sedation and neuromuscular blocking agent, mechanical ventilator settings, the prone positioning, monitoring in the ICU, and adjunctive treatment, supportive treatment, organ support, and general patient care issue. I will start with intubation issue. My recommendation is intubation should be done early in patients who fail to respond to simple oxygen therapy devices. And setting up the system to support this procedure is essential. This makes us to avoid using the NIV, which leads to the aerosol dispersion, and reduce the chaos for unplanned intubation in the negative pressure room. The criteria I show in my slide is used for identifying candidates for early intubation. We consider intubation in patients with the pulse oximetry less than 92% at room air, or the pulse oximetry between 92 to 95% at room air with the respiratory rate is higher than 30, or the respiratory rate less than 30 with the signs of impending respiratory failure. This slide shows the aerosol dispersion distances in various devices. You will see the shorter distance observed in the high-flow nasal cannula and non-rebreathing mask. The highest is found in the NIV. So if you do not intubate early, you may use the high-flow nasal cannula. I do not recommend to using the NIV for this patient. The recommendations for providing the high-flow nasal cannula are using the high-flow nasal cannula in negative pressure room. And the patient should wear surgical mask cover the cannula. Healthcare personnel should wear a N95 mask during visiting the patients. The flow should be set at 40 liters per minute. If higher requirement, intubation should be considered. If the pulse oximetry less than 92% despite high flow nasal cannula or respirator more than 30, the intubation is required. The sedation should be given to all mechanical ventilated patients. The disease causes high respiratory drive and effort. So the deep sedation should be a goal. We use BIS monitoring for targeting sedation level. In severe RDS from COVID-19, the neuromuscular blocking agents is essential. This aims to get rid of patients' effort that may cause further lung injury. Because most of patients develop hypotension from deep sedation, so norepinephrine infusion is required. This is a sedation protocol we developed for COVID-19 ARDS at Ramathibodi Hospital. The first step is sedation without neuromuscular blocking agent. And the second step is neuromuscular blocking agent. The next topic I will talk about is how to set the mechanical ventilation in COVID-19 with ARDS. The answer is setting mechanical ventilation to protect the lungs from ventilator-induced lung injury. To protect the lungs, we must use the optimum PEEP and low tidal volume strategy. The optimum PEEP should be guided by the respiratory system compliance. You will see in the slide for the formula of respiratory system compliance. In general, if you are not familiar with the recruitment maneuver, I suggest you use the ascending PEEP titration to find the optimum PEEP level by keep the tidal volume at 6 ml per kilo predicted body weight and increase the PEEP from 8 to 10 to 12, 14 until 20 centimeters of water. At each level of PEEP, measuring the respiratory system compliance. The PEEP level give the maximum compliance will be chosen. But if you perform the recruitment manual routinely, I suggest the decremental PEEP titration to acquire the optimum PEEP. After you get the optimum PEEP, the tidal volume should be set at 6 ml per kilo predicted body weight, and the bladder pressure and driving pressure must be kept in safety margin as I show you in the slide. Other than the compliance, I recommend using the lungs ultrasound to assess the lung recruitment to identify the PEEP. Or the PEEP is used to open the lung is required. The ultrasound should be used in other purposes, such as its responsiveness assessment and hemodynamic monitoring. This diagram shows the decremental PEEP titration after recruitment manual. You will see the optimum PEEP is 12 that provide the respiratory system compliance 28, that is the highest level. In our practice, the prone positioning is indicated in case of fail to improve PaO2 over FiO2 ratio more than 150 by mechanical ventilation. We prone the patient for 16 hours. If the oxygen cannot be maintained during supine period, repeated prone position is performed. We found very good response of prone positioning in ARDS from COVID-19, so we suggest to think about early prone for all severe ARDS patients. We need 5 to 7 people for performing prone positioning as shown you in the figures. And awake prone is very interesting. It may be an alternative for correct hypoxemia in non-intubated patients. However, I recommend awake prone positioning with high flow nasal cannula, and temporary desaturation during supine would be observed. The next topic is monitoring in the ICU. The monitoring in the ICU to take care of the patient with COVID-19 is similar to the other patients. We need to monitor vital signs, ECG, pulse oximetry, entitled carbon dioxide monitoring, arterial blood gas, lung mechanics, lung imaging, the cardiac output, blood chemistry, especially the renal function, and fluid intake and output. You may create the ICU checklist to improve patient care in contagious COVID-19 infection. It plays a role as a reminder, can reduce error, or facilitate patient care. Besides the antiviral drugs, there may be role of the adjuvant therapies such as systemic corticosteroid, interleukin-6 inhibitor. Our experience, the interleukin-6 inhibitor may be beneficial in terms of fever, the chest X-ray resolving, and the gas exchange improvement in some cases. The prevalence of acute pulmonary embolism quite high in these patients, so all respiratory failure patients should be given PE prophylaxis. The complications in severe COVID-19 cases. The airway obstruction and atelectasis is very common. The pulmonary embolisms, you need to monitor the oxygenation and may need to perform the CT scan to identify pulmonary embolism in the patients. The ventilator-associated pneumonia, acute kidney injury, and seizure For supportive treatment, the fluid management is very important. In ARDS, the fluid overload is prohibited. Keeping the lungs dry is preferred, but in the COVID-19 ARDS, the acute kidney injury is an early complication and may lead to death. We recommend using the fluid responsiveness parameters to balance risk and benefit of fluid therapy. We recommend to use power pressure variation, which you can see it from the screen outside the negative pressure room. So we allow the tidal volume of 8 ml per kilogram predicted body weight for ARDS COVID-19 to ensure the accuracy of the power pressure variation for predicting fluid responders. About the organ support, we will be talking about the extracorporeal membrane oxygenation and renal replacement therapy. Thinking about the complication first, if the PF ratios declines. The most common complications in COVID-19 that cause hypoxemia are the secretion obstruction and pulmonary embolism. If the complications are absent, initiation of ECMO should be considered without delay. The outcome from our experience is good. The indication of renal replacement therapy in COVID-19 is similar to other diseases. The general patient care is the important issue as well. The respiratory care, you need to use closed system suction as frequent as possible. You need to monitor airway obstruction by secretion, observe water retention in the ventilator circuit, and equip the viral filter at expiry limb of ventilator circuit. About the pressure saw, because ARDS patients are prescribed deep sedation and neuromuscular blocking agent, so they are at risk to the pressure saw. Use standard protocol for prevent of pressure saw. Do not limit any care for COVID-19 patients. So you need sufficient PPE to essential and unlimited patient care. That's all I would like to talk today, and thank you for your attention.